Hello, it's Andrew Eborn here with another edition of very special guests and very special lives on lockdown, and looking today at orthodontics with Orthodontist of the Year, Claire Nightingale. Hello, Claire.
Hello, Andrew. Nice to see you.
How are you? It's always, you're a regular on the show now.
Yeah, no, I'm still feeling good. Thank you very much.
So a lot of people have written in and said it would be wonderful to understand a bit more about the procedure, all the different types of treatment and so on and so forth, and what to expect from everything from are they suitable to be a patient, to what sort of results they could expect, to what sort of time period it might take, and also looking at specific treatments and talking through those. Is that something you can help us with?
I believe I probably can. Let's hope. Fingers crossed.
Brilliant. Okay, well, let's have a look at those.
Okay. So, Andrew, I thought that probably the most sensible thing to do would be to talk to you with a degree of visual imagery. So that will help, because as a picture speaks 1,000 words, you know, maybe I can show different photographs which I have on my website, and then we can talk around any images that you wish. So where would you like us to start?
Well, why don't we start at the very beginning when people, an early child sounds good. So I guess the first question is, how old would your youngest patient be? At what age would you like to think of seeing people?
Well, I mean, first of all, I would hope that children are under the care of a general dental practitioner that will be astute enough to identify deviations from a normally developing malocclusion, and that they will send me patients who they think they need a specialist opinion for. Okay, so number one, every child should be under the care of a good dental practitioner. However, as a rule of thumb, ideally, every child would be seen around the age of 10. Because obviously specialists will pick up on problems that a GDP may have missed. And in particular, the most critical thing to know about a developing dentition is where the adult, so the permanent canines, the adult canines, are they developing in the right place? And it's very, very simple. So GDPs can palpate, specialist orthodontists can palpate just under the lip here to see if we can feel the canines in the right place at the age of 10. That's the critical thing. If we can't palpate the canines at the age of 10, then we should be taking radiographic assessments to find out where they are, because there's some interceptive treatment that can be done at an early age to stop the canines deviating off course. So in a nutshell, adult canines start developing very high up near the orbit. So that's where they get the name eye teeth. They have a long way to grow down, to erupt, to come into the right place. And during that process, they can deflect and go off course and end up in the palate. When they end up in the palate, it's then a lengthy process to haul them out. And I think, and as an NHS consultant, I'm seeing a massive increase in referrals of kids who have impacted canines in the palate. And the problem is that they're often picked up late. They're often not picked up until the child is 15, and that's because baby teeth have been hanging around and the dentist has been erroneously waiting for the baby teeth to fall out, not realizing that the underlying problem is that the teeth that were meant to be pushing them out have gone off course. And it's not a happy situation to be telling a 15-year-old that they're going to require a 3-year course of treatment to make them look no different, because quite often these kids have actually got straight teeth. So, so anyway, so in a nutshell, really every child should be seen by a specialist orthodontist by the age of 10.
Okay, that's very helpful. And the way you can do that is one of two ways, as you say. It's with your regular dentist, or can you go directly to have a consultation?
Well, in the private sector in which I practice as an orthodontist, yes, I will accept self-referrals. In the NHS, it's not so straightforward. So in the NHS, there will be a process required whereby a dentist will have to make an electronic referral to the appropriate provider of orthodontic care in their area.
So ask your dentist is the best advice for most people.
Yes, absolutely. And if you want to have private treatment, then ask your friends. You know, a word of mouth recommendation speaks volumes.
And I think, especially for dentists, word of mouth is the operative word. So that's all good. Very good. So you go along, the ideal patient being a 10-year-old, you have a look, and then you tell them a number of things. Talk about that first examination and what you're looking for.
Okay, so actually let me backtrack a fraction and say to you that the age range under my care at this moment in time is 8 to, would you believe it, 81.
Wow.
So actually, yeah, so I've got a huge age range of people that I'm looking after, but I'm not really going to be offering treatment until the permanent teeth are through. Of course, I'm not going to be shifting baby teeth, okay, as a general rule. So, you know, given that the adult permanent teeth don't erupt until the age of 7.5 or 8, ergo, my youngest child is 8. And what I'm doing in that instance is something very simple, and it would just be pushing a tooth, an anterior tooth forwards out of crossbite, for example. Now, let me just have a look. It's been a little while since I've visited my website. So let's see if I have any images there. So yes, okay, so let's just have a look at down here to begin with. So here we have a child, these are baby teeth, these are adult teeth. So we describe this stage of dental development as being the early mixed dentition. So it's transitory between the eruption of the adult teeth and the loss of the baby teeth, okay? So this child has got 4 anterior adult incisors, of which these upper lateral incisors are crowded and trapped in crossbite. Now, you know, the NHS may well not correct this, may not allow the funding because it can be corrected at a later date. However, there are 2 reasons why I do like to correct these. The first is because although there's no science to back this up, if I correct it earlier, I believe that I can get the root position into a more normal place earlier, and that should ideally make the chance of stability longer. So by that, the probability of stability. So what I mean by that is these crowded teeth are relapse prone. So if they're very crowded, they will start to try and go back to where they started from, probably because the root of the tooth is still in the palate. Now, if I treat this patient slightly earlier, then maybe I can get that root forwards, and maybe that tooth is going to stay straighter for the longer term. The second reason why I like to do this treatment is because I want to protect the integrity of the tooth surface enamel. So you can imagine that a tooth like this, for example, that's biting on the wrong side of this canine. So this lower canine is going to contact the tooth surface of this enamel, and it's going to start to attrit it. It's going to start to wear it down. And part of the beauty of a smile is, of course, having intact dental enamel. So from an aesthetic point of view, I, as an orthodontist, can influence tooth position, but I can't influence tooth shape. And dental enamel, when it's lost, it's lost. We can't replace dental enamel. So if a tooth edge has become worn, then that child is going to end up with a jagged tooth for the rest of their lives unless they have some cosmetic dentistry. So those are the 2 fundamental reasons. The third reason, well, actually the most important reason, is if I identify that there's a problem with the gum health of the tooth as a consequence of the crossbite. That's the most important thing. And also if in fact having a tooth in the wrong position is causing the patient to shift their jaw around, hunting for a correct bite, and we call that a displacement. So if I summarize then, in terms of why I would treat a patient at this age, is number 1, to protect their dental health, so protect their gum health and protect the integrity of their tooth enamel. Number 2, to give them a functional bite so that when they close their teeth together, they don't swing their jaw off to one side because they're hitting a tooth prematurely. And the third reason is my suspicion that by correcting it slightly early, it would increase the stability of that tooth position for later in life. Okay, so those are the reasons. So I would use a simple removable brace just to get these teeth straight. And if the child can't tolerate it, then I might move to a simple fixed brace. But what I'm really interested in is making sure that that child gets the best outcome for their treatment in the shortest possible time, because I do not want to run out of cooperation for when the real job will need to be done, perhaps, when all of their permanent teeth have developed. That said, I actually corrected my own daughter's teeth very simply with a removable brace when she was about 8 or 9. And in fact, she didn't really need to have fixed braces later on. So by a simple intervention early on, fixed braces became a luxury option for her rather than a necessity. Okay.
And
now,
so very, very easy to understand. I think the earlier the better. Once those permanent teeth are in, it's worth getting an expert opinion, because that early intervention could save a lot of trouble later.
it could do, but it has to be only if it's in the best interest of the child. Okay, it must not become a money spinner for the orthodontist. Let's make that absolutely clear. I only want to treat people if there's going to be a clinical benefit for them.
Okay.
So this next patient, now this was a very interesting one for me because, and in fact, I'm in the process of writing this young lad up as a case report. So he has something called an anterior open bite. So his front teeth aren't meeting. You can see that there's a lot of fresh air. They're meeting at the sides, but they're not meeting at the front. And yet, hard for you to see on just a front-on shot, but I'll tell you that his teeth were proclined. So his lower and his upper incisors were leaning forwards. Now, I have come to the conclusion that the reason for this was because of the behavior of his tongue. Okay, so tooth position can be influenced by a number of things, one of which is the behavior of the soft tissues. So this young lad had a tongue that sat forwards of its ideal position. And the tongue is fundamentally a bag of muscle. So the tongue was causing the teeth to be proclined and also to be apart. Now, they actually came to see me for a second opinion. So they'd seen someone who'd suggested taking out his first permanent molars. And I felt that, although I hold this orthodontist in high regard, I felt that that wasn't the right answer for this young lad, because actually what I felt he really needed was to get the tongue away from his teeth. So I gave him a brace which I haven't used a huge amount. Here it is. This is called a Myobrace. Now, it's actually very comfortable. I've tried one in myself. And what this has, you can't see it from this shot, but it has a place where the tongue is caught. On the inside, it has a tongue positioner, if you like. And so I gave this lad one of these, very simple, just opened my cupboard, took out a Myobrace, gave it to him. He has to wear it a lot. He had to wear it a minimum of 12 hours a day. And of course, you have to get used to it. It falls out at night, for example. So most of those hours come from when a child is asleep. And I have to say that my experience with it is very hit and miss. Some kids have gotten extremely well with it. For some kids, it's been a complete disaster. But I think that those that persevere and wear it for 12 hours plus a day have had some very good results. And look what happened within all I had to do. So I literally just gave him a series of these plastic braces to wear. And over a matter of a few months, look how the bite has closed down.
And that's just with that Myobrace, just with that
Myobrace. And the principle has been get the tongue out of the way, keeping his tongue out of the way of his teeth. So removing the etiological factor meant that the teeth then erupted and were able to come together. Now, at this point, his teeth are straight, his bite is much better. There wasn't the clinical necessity as such to do anything more. So, for a sequence of 3 braces worn over a period of 12 to 18 months, whilst his adult teeth were erupting, he treated out. Okay. Now, as it is, this degree of overbite doesn't entirely satisfy me. I'm still looking for improvement. So we did go into some fixed braces, which were only an 11-month course of treatment. So actually, from this rather challenging starting point, he had extremely straightforward treatment, wearing easy removable braces over a period of about 18 months, after which we tied it up with conventional train track braces for 11 months. But I don't think that I would have been able to go from here to an improvement on this with fixed braces alone. Okay. So, yeah. Okay. So those, and then of course, so that's pretty much the limit of my early treatment of children. Okay,
very good.
So now we'll go on to the next stage. So, so if I see a child under the age of 10 or 10, let's say, then that's the sort of treatment that I might be offering them. So now let's move into the next kind of age group. So we're looking at the sort of on the cusp of adolescent children, really, and we're talking about kids here that might have phenomenally goofy teeth. And okay, so here's one I did earlier. So this young lady, her teeth stuck out from memory, they were about 13 millimeters. So given that the ideal range is 2 to 4 millimeters, a prominence of teeth, and we call that an overjet, a 13 millimeter overjet is a large overjet. Okay, and the reason for that was because her lower jaw is short. So you can see that her chin is set back quite some way from her face. So if I was to drop a vertical line from the curve of her upper lip, and this is one of the measures that we think about, ideally the chin point would sit on that vertical line. So you can see straight away that there would be about a centimetre gap, which is contributing towards the prominence of her teeth. So fundamentally the bone is too short. And when you have a bone that is too short, the soft tissue that is stuck on that bone, so the lower lip, which is attached to the bone, is therefore in the wrong place. So this band of muscle, so in the way that I talked about a tongue being a bag of muscle, lips, of course, are bands of muscle. And bands of muscle can act as natural retainers. So when we have our lips together, our lips are acting as a natural retainer on our teeth and keeping them back from being prominent. When you have lips that can't meet together because the bones are fundamentally wrong, or the lips haven't grown enough, the lower lip is sitting behind the top teeth, and it's become something that's described as a lip trap. So this is a lower lip trap, and you can see very visually that the upper incisors are sitting on the lower lip, which is causing them to push forwards. So her overjet, the magnitude of her overjet was as a consequence of the short bone combined with the lip trap, with the lips not being able to come together. So what I did for her was I gave her what's called a functional appliance. So she had twin blocks. In fact, these may well be her functional appliance. And the purpose of this appliance is to push the lower jaw forwards. So this particular appliance comes in two halves. One goes on the top teeth, one goes on the bottom teeth. And this is the active part of the brace. So where these blocks meet, the patient is forced to protrude, forced to push their bottom jaw forwards. The consequence of that is multifactorial. Number one, it gets the lip out of the way of the upper teeth, so one problem is eliminated. That means that the muscle of the lip can then touch the top teeth and tip them backwards. And in addition to that, because the bottom jaw is postured forwards, we get a little bit of bony remodeling of the jaw joint, which helps bring the bottom jaw forwards. And the final factor is that we hope kids are going to grow during this stage. So we steal a little bit of benefit from multiple corners, from bone growth, from bone repositioning, from soft tissue repositioning, but mostly from teeth tipping. Okay, and what I'm showing here on my website is a number of different appliances, and they all effectively do the same thing. They all do the same thing. It's just that, it's kind of horses for courses. Different children will tolerate different appliances, and I will have a favorite depending upon the clinical presentation. Okay, so on the whole, these functional appliances, which are removable plastic and wire appliances, are largely trying to do the same thing, which is reposition short lower jaws and tip teeth. Okay. You can use them for the reverse problem, a long lower jaw, but I tend not to, because they don't tend to be terribly effective in the longer term. But certainly in the UK, functional appliances are very commonly used, and the time that I will use them is in the late mixed dentition. So I will use them as a means of correcting prominent teeth whilst waiting for other adult teeth to grow through. So it's a very neat way, in a relatively non-invasive way, of correcting a problem whilst allowing baby teeth to fall out. Okay.
And obviously it will vary on patient by patient, but roughly how long would you expect that course of treatment to last? 9 to 12 months, most likely. Okay, and then ordinarily you would then go into the next phase of treatment, which would be fixed braces. However, very occasionally I have had a patient that's not needed to progress to fixed braces because their teeth have already been straight. It's just that they've been goofy, and we've corrected the goofiness, and then the teeth, then they're done with straight teeth. So that would be functional braces. So now let's look at fixed braces. Okay, so here we have, so this actually is my receptionist. So when he came to start working with me, he actually had lingual braces on. He had braces on the inside of his teeth, which he persisted with
for a considerable length of time, but it didn't quite get him finished. So he has finished his orthodontic treatment with attractive ceramic brackets, so aesthetic brackets on the front of his teeth. And here is my daughter. So although I was explaining that orthodontics was optional for her, but she decided to have a little bit of treatment, and she had white braces, but being a teenage girl, she decided to jazz them up with a little bit of colour. So that's how she's looking. And then then this photograph here, this is one of my cases that I'm particularly proud of, because he started off with a really stonking malocclusion with his teeth completely on the wrong side, his bottom teeth on the wrong side of his top teeth, severe crowding, one tooth completely outside. And I thought laterally and treated him out without him actually having to lose any teeth by a combination of expansion in the top and self-ligating brackets, which are very low friction. And I use low friction brackets when I'm trying to achieve the impossible. That's when I use low. So, so I look at him and I think, how is it possible to treat a malocclusion of this severity without either resorting to dental extractions or surgery? Okay, so I pulled a rabbit out of the hat and thought laterally and achieved that. I'm going to call it a miracle. But we were very, very happy. So that's when I use self-ligating brackets. So a common brand is Damon. I'm using Smart Clip. They're not my primary choice, but I use them when I'm trying to achieve the impossible. So fixed braces are these are labial fixed braces, so bonded on the lip surface of the teeth, and they are the bread and butter of modern orthodontics. Okay, so tried, tested, easy to adjust, deliver, but they're not very pretty to look at. You can get food trapped around your teeth, and then you go off to grin at someone without, you've got that social embarrassment factor. But they are reasonably efficient. And as I said, tried and tested. So bread and butter orthodontics.
Very good.
Yeah. Now let's have a look at the next. So Invisalign. So obviously we have just been talking in a previous episode about Invisalign. So this is a clear aligner. So this is something that's made out of clear plastic. It's vacuum formed around the individual tooth surface, and a small amount of tooth movement is built into each one. And the patient wears these clear aligners sequentially. Okay, so the advantage, there are huge advantages. The advantages are clearly aesthetics, comfort, convenience. Okay, the downside is that somebody has got to wear something that is removable. So you've got to be disciplined, to do this. And I'm not sure that I personally would be disciplined. And when I had orthodontics, I chose to have fixed braces. But for the vast majority of adults, I'm now treating pretty much all my adults with clear aligners. So here we have a case study to show you. So this lady had an anterior crossbite. Okay, so what that means is that her upper teeth are trapped behind her lower teeth. Now, if you come back to the very first thing I said to you about why do I like to treat anterior crossbites in a growing child, and I said one of the reasons was to protect the integrity of the tooth enamel. So have a look at how her tooth enamel has worn. So do you see this? Yeah. So here is a normal height lower incisor, okay, and then here the incisal height has been reduced. The crown height is worn because of the traumatic occlusion. And indeed, of course, it's always at moments like this you realise the deficiency in one's record keeping, and how much more convinced you would be if I was able to show you a photograph with her teeth apart, and you would see that the labial surface of her upper teeth had worn in a similar fashion. Okay, but guess what? I didn't take the photo.
That's all right. We'll make it look good in the edit.
You'll take it from me that she had an anterior crossbite with tooth wear. Okay?
Yeah, I think we can see the pattern of that. And as you said earlier, the only way you can correct the worn down teeth is cosmetically, isn't it?
Yeah, you've got to restore the tooth surface somehow. So now, of course, this is absolutely something which you would really hope would be corrected for an adolescent. You know, you'd really hope that in the world of contemporary orthodontics, we wouldn't have a child who got to adult later in adult life with an untreated problem like this. Okay. However, as you know, when we were growing up, the world of opportunity in dentistry was vastly different to how it is now. And indeed, I was able to treat this lady out using Invisalign and getting her to wear elastic bands, just analogous to the case that I showed you in our previous discussion. And she treated out beautifully. So her orthodontics was tremendously efficient. She treated out within 9 months, and then her dental practitioner, who's very skilled, restored the incise, restored the labial surface of her front teeth with composite. And of course, she was delighted. She was delighted, you know, for a very short investment of time.
Yes. And again, just talking about time period on that one, particularly, how long did that take?
9 months.
9 months, so it's relatively quick.
Absolutely, absolutely. Yeah. So again, you see, as I was talking to you about the efficiencies of clear aligner therapy versus fixed appliances, you know, so I'm not going to tell you that treating someone with clear aligners is going to be ideal for every case. But now I do tend to think of it as my first appliance for adults. And it's almost if it's not possible, why is it not possible? And of course, as I'm becoming more experienced as an operator, I'm becoming much more confident in the approach, and I'm becoming much more adventurous in the sort of problems I can treat. But of course, the difference between me and someone who isn't doing the volume of orthodontics that I do, so you asked me some time ago, what is the difference between me as a specialist and a general dental practitioner? And perhaps I missed the most important thing to tell you, which is, of course, all I do is orthodontics. Right. Day in, day out, year after year after year, all I do is braces. So, you know, I'm clocking up 35, 40 hours a week of clinical time, and I've been qualified for, you know, 23 years. So my level of experience and expertise is factored on those thousands of hours of doing treatment. So I know that if I can't treat someone out with Invisalign, guess what? I can then treat them out with ordinary braces, you know, and if they need jaw surgery as part of their correction of their malocclusion, guess what? I've got access to great surgeons with whom I've worked for a number of years. So, you know, there's nothing that's going to faze me now. So yes, if it doesn't work with Invisalign, I can switch to another modus operandi.
And that is an important point to make, isn't it? Because I think it's the voice of experience. You've been there, done that, seen virtually everything, I would have thought, by now.
Yes, but I am also going to say that doesn't make that I'm still remaining reflective. You know, so that doesn't mean to say I've got all the answers on day one. I'm always learning. Every day there's a learning opportunity. Everything's about reflective practice and improving and embracing the opportunities. Because of course, as we've talked about, there's developments all the time. You know, nothing stands still. And if you stand still, you're doomed, aren't you? So, right. Okay. So what else have I got to share with you? So lingual braces. Okay. So braces on the inside of the teeth. Okay. So, I mean, very innovative, highly precise engineering, phenomenally difficult for me as an operator. I'm not very keen on them. They're great for, they're really good for patients in the sense that you can't see anything. But as a means of getting comfortable, you know, imagine your tongue rubbing alongside these appliances all the time, and the consequences for speech as well. And then if a bracket, so these are highly precision engineered for the individual patients, and this particular system is actually engineered in Germany. So every time a bracket falls off, which it does from time to time, you've actually got to get a new one manufactured in Germany. You can't just open the cupboard and pull out a new bracket. And then in addition to that, the bracket, sticking the bracket on the tooth is very difficult because it's very sensitive to both saliva and blood. So if you have any gum inflammation with a bit of gingival bleeding, and you can't get an entirely dry field. So again, that affects the bracket strength. Now, I do have a friend who does lots of lingual orthodontics, and he would take me to task, I'm sure, for being so dismissive of lingual braces. He does high volume, very experienced, super operators. So in the right pair of hands with the right enthusiasm and the experience, they will work out very well. But it's not that I won't offer it, I will still do it. But I'm now finding, well, if somebody doesn't want to wear, you know, well, if I can treat someone out with Invisalign, why wouldn't I then have the activation of lingual braces? But, you know, here is a case that worked out very, very nicely for me with lingual braces. So a woman with here we go, look, here's the anterior crossbite that I would rather have seen corrected, as you now know, earlier on. Lingual crossbite, tooth in crossbite and a displaced canine and a posterior crossbite. She wore braces on the inside of her teeth, top and bottom, treated out very nicely. Okay.
The advantage, the main advantage of it from the patient's point of view is cosmetic. People don't see the braces. Is that the idea?
All about the aesthetics.
Right.
Yeah, exactly. So, and apparently, the history of lingual braces is that apparently there was an American orthodontist, and that we might be going back to the early 80s, who was treating a few bunny girls with braces, and they of course didn't want to be wearing metal braces on the outside of their teeth, so he started trying to treat them by fitting conventional braces on the inside of their teeth. And apparently a journalist went to interview these bunny girls about something, but got distracted when he caught sight of the metal braces on the inside of the teeth, so the interview ended up being about something completely different. But that apparently is the source of the first pioneer in lingual braces. And I have to take my hat off to anybody who puts themselves through the pain of being on that early learning curve. And of course, you know, it was so phenomenally difficult that it went on the back burner for a while. And then a very innovative German chap called Dirk Wiekman has really embraced lingual appliances and brought them on a long way, and it's all been taken to the next level. But I've tried it, not really that keen. You know, I'm falling in love still with Invisalign and wanting to do more with that.
Embrace the braces. I like that idea.
Embrace the braces. So anyway, so there we go. But lingual appliances are still an opportunity and still appropriate in the right cases. Okay,
very good.
Now let's see what else I want to tell you about. So, okay, so this is a subject that's close to my heart. Orthognathic surgery, so jaw surgery. So, you know, as an NHS consultant and also in my private practice, I work with a number of adults who need to have jaw surgery to correct an underlying size mismatch of their jaw bones. Okay, so I'm finding that the analogies that I use are lost on younger people, but you will remember Jimmy Hill, Bruce Forsyth, and Desperate Dan.
Absolutely.
Who is a contemporary character today with a big chin? Can you think
Hill, but you've got that sort of side. Well, there's a few. Anyway. Any of those sort of people, you get the idea, because
either we're looking at people with phenomenally long jaws, or we're looking at people with short jaws, or we're looking at people with gummy smiles, for example, or we're looking at people with wonky faces. So somebody who has got a problem with the underlying jawbone. And of course, as I've said to you before, as an orthodontist, I can move teeth. I can influence the position of teeth, but I can't influence the position of a bone. That is done by an orthognathic surgeon. So orthognathic surgery is teamwork between an orthodontist and a surgeon. So first of all, of course, it's all about diagnosis. It's about identifying that the patient has got a problem that isn't amenable to treatment with braces alone. Okay, then it's having a discussion with them about the treatment opportunity. Some people aren't interested in surgery, some people are. And of course, what I will also say is that surgery's come a long way. So, you know, 28 years ago, when I first started working in a maxillofacial unit, patients would sometimes have their jaws wired together post-operatively. They'd be in intensive care because they had the jaws wired together. They might be in hospital for 4 days. We might set aside an entire day of operating time to do their jaws. That's all changed. You know, now it's 1 night in hospital, maybe 2. The surgery can be wrapped up within 4 hours. Sometimes, you know, the surgeon with whom I work most closely has done an osteotomy in 3/4 of an hour. It's not perhaps so much more different than having wisdom teeth out if you're just having surgery to the bottom jaw. So, and of course, patients, when they wake up, they now have a kind of a special mask that goes over their face, and it puts cold water icy water over their face so it minimises swelling. And patients now come and see me a week post-operatively, and frankly, you'd struggle to know sometimes that they've had anything done. So, you know, I don't want to minimise it, but I do want to remove the fear factor and the misconception about the degree of trauma that patients go through to have jaw surgery, because it's not like that anymore.
So are you saying that Jimmy Hill and Bruce Forsyth and others, Desperate Dan with big chins, needed some sort of surgery to correct it?
I am. Yes, it might affect, well, you know, only if it bothered them, let me say. And clearly it didn't hold Bruce Forsyth, it didn't hold Brucey back, did he? And neither did it hold back Ken Dodd either.
Oh, absolutely.
You know, these days, do children want to grow up looking like Ken Dodd and Bruce Forsyth? You know, they at least they have a choice now as to whether they want to or not.
Right.
Okay. So, and this is not pioneering. There's nothing groundbreaking about this. The first sagittal split osteotomy was developed in the 1950s. So, you know, we've got many decades now of these surgical techniques under our belt. So, under our belt even. Right. Okay. So let's look at this gentleman. So, this gentleman has got a very short lower jaw. Okay. Now, there were consequences about this lower jaw. So, you know, if he had been bothered about the aesthetics, he would have come in and complained that he was chinless, perhaps. And, you know, and there are a number of people that do really dislike their profiles and want that addressed. It wasn't the case for this gentleman. His problem was that because his jaw was so short, it meant that his tongue was sitting very closely back to his pharynx, which is his airway, and he was suffering from something called obstructive sleep apnea, which meant that he was waking up multiple times an hour gasping for breath. And that had and obstructive sleep apnea has massive negative health consequences and is becoming an increasing problem in the population. And it's something that I'm becoming increasingly interested in, because and I've now treated maybe 5 or 6 people that have had jaw surgery as a means of trying to give them a permanent solution to their obstructive sleep apnea. Because obstructive sleep apnea has massive consequences. It has a role in the evolution of diabetes, high blood pressure, heart disease. You know, people with severe obstructive sleep apnea can't drive lorries. You know, there are implications in road traffic accidents. And in addition, of course, there's the consequences for your spouse or your bed partner, let's say, to use a term. You know, so, and the options at the moment, the gold standard for treating sleep apnea is something called CPAP, which I'm sure you're aware of, which is a very unattractive mask that fits over the mouth and nose, and oxygen is pushed into this mask under positive pressure. So continuous positive pressure, airway pressure. However, they're noisy, they're unattractive. And as one of my patients said, she could never go on holiday without worrying about would there be a socket in the proximity of the bed that would allow her to plug her CPAP machine into. And this is a young woman who was only in her 20s. So, you know, so I think of all the work that I've had the privilege to do in my career, this is the really life-saving treatment that I do. So I do a lot of life-enhancing treatment, but in terms of where does an orthodontist become part of the provision of care that is life-saving, and this is it. So this gentleman, he had a combination of braces, so I prepared him for his jaw bones to be moved, and the surgeon with whom I work most frequently moved his jaws maximally forward. So this gentleman has had his top jaw brought forwards by about 1 centimetre and the bottom jaw forwards to match. So the bottom jaw probably came forwards by about 15 to 18 millimetres. And the combination of that means that the soft palate, which is attached to the top jaw, is brought forwards away from the back of the pharynx, as is the tongue. So by moving the jaws forwards volumetrically, the airway is opened up enormously. And also the effects are immediate. So the moment this chap came round after his surgery, all of a sudden his sleep apnea was pretty much cured. Okay. And the consequence...
How much can the jaw be moved?
Well, the exam answer used to be about 1 centimetre. Okay, that was the parameter within which we were advised to work. But actually, the surgeon with whom I work more frequently is bringing the jaws forwards further. Perhaps he's developed particular techniques to try and reduce the risk of relapse, because that's what we want to avoid. We're looking for a permanent correction as far as is reasonably achievable. We don't want to put people in a situation where they get a recurrence of their presenting complaint. Okay, so on that front, what I should say is that jaw surgery, particularly for people for long jaws, is done at the end of skeletal growth, so that the problem can't grow back again. So, and my role in it, so I describe the journey as being like the creation of a jigsaw. So the idea is that the orthodontist gets the teeth straight and unravels the work that's been done by Mother Nature to compensate for the underlying jawbone discrepancy. And then, so I create a jigsaw puzzle, and then the surgeon assembles it. And then I tidy up the jigsaw puzzle pieces at the end. So it's very important to have a teamwork approach with people that understand how we like to work together, that there's really good communication between the orthodontist, the surgeon, and the patient. And of course, we're not talking about a short course of treatment. You know, we're talking 2 years, maybe longer, to get this sort of problem sorted out. But in terms of the lifelong benefits for the patient, it's huge. So, you know, sometimes we're doing it because there's a traumatic occlusion. Sometimes we're doing it because there's a facial aesthetic issue. And now increasingly we're doing it as a life-saving measure, which might sound dramatic, but I believe that's a real reasonable thing to say, to address somebody's obstructive sleep apnea. So this gentleman, you know, he doesn't wake up gasping for breath like he used to. His cholesterol level's gone down. He's lost weight. He's got energy. You know, massive quality of life benefits. So I hope that gives you some insight into jaw surgery. And then the final things that I do. So for you know, we wouldn't jump into operating on somebody's jaws to correct their obstructive sleep apnea as the first choice of treatment. Of course not. You know, we've got other things that we can offer, and we would want certain that the patient was going to respond correctly before they had treatment. So this is something that dentists and orthodontists can offer their patients. This is called a mandibular advancement splint. Okay, so this particular product is called a Somnoel appliance. It's made out of cast cobalt chrome, so it has some longevity, and it's a very bespoke appliance for the patient. So again, you know, precision manufactured. But the key here is these pistons. So what you have here is you have an attachment over the top teeth, you have an appliance that attaches to the bottom teeth, and then you've got a piston that pushes the bottom jaw forwards. And in doing so, that's the mechanism of getting the tongue away from the back of the throat and opening up the airway. Okay, and the advantage of this particular appliance is that the patient can open and close their mouth comfortably during the night if they need to, so they can drink water, for example. And it can go in the dishwasher. It can last for many years. The downside of this is that it can cause subtle changes in the bite and the occlusion over many years of use. But as an alternative to a CPAP machine, it's a big plus. And it's an, you know, and of course many patients are wearing these, and they're just wearing them at night, of course. So that's another part of my clinical practice. And then I suppose the very final thing which I might offer is management of jaw joint discomfort. So and I haven't got any photographs, I see, but you know, at times of peak stress, we all tend to clench our teeth and grind our teeth. And I can give people simple splints, removable splints to go over their teeth, to give them a more comfortable surface to grind against, that helps helps protect the teeth from tooth wear while someone is grinding, and also helps relieve the pressure on the muscles, perhaps, as a consequence of the nighttime grinding. Because a lot of jaw joint discomfort actually arises from muscle pain, and not actually inside the joint itself. So there you go. That's a whiz guide to the sorts of work that I do in my clinical practice and the sorts of treatments that I can offer.
And a fascinating insight, Claire, as you say, everything from the cosmetic to actually the life-changing, and people who have snoring partners and things like that would be very grateful to hear there are alternatives and there are treatments that can be done. And it's a lot wider, and understanding, putting it into context, the different treatments that can be done. It's very, very helpful for people to get that sort of knowledge early on, because knowledge is powerful, isn't it?
Absolutely, absolutely. And, you know, and you also wanted to know a little bit about the patient journey. So, you know, the patient journey is in the process of change, of course, because of COVID. And we're looking at ways to minimize patient contact, you know, patient to patient, patient to staff. And of course, we're also moving into a world of digital technology and virtual monitoring of patients. So, you know, the patient journey that I have historically embarked with, you know, in a few weeks' time, it might be vastly different. But, you know, I have embraced technology. So so I have now got an app on my website, which I know that you're going to trial. So patients can send me their photographs ahead of a consultation, so I can get the gist of their problem before they come in. However, obviously nothing is ever going to remove the necessity for a face-to-face consultation so that we can truly assess somebody's dental health and discuss treatment options, although that can be done, of course, over Zoom calls. But I have a scanner, so, you know, I'm moving away from taking gungy molds of people's teeth. I'm looking now at trying to scan everybody. So that scan might be it's not quicker than taking an impression, but it might be a bit more pleasant for the patient. But I can now share that scan with my laboratory over the internet. That scan is also a permanent record of their teeth. So, for example, while I've been on lockdown, actually I've had more numbers of telephone calls of patients who've lost retainers than I have of patients who've been in trouble with their fixed braces. Okay. Now, if I was in the lucky position where I had been able to scan every patient that had ever finished their orthodontic treatment, I would have been able to solve their problems by emailing their scan to my laboratory, who would have gone in and especially opened up to manufacture a new retainer for that patient, which would have been sent to them in the post, you see? And all that way would have meant that there was no patient contact, no attendance of the patient in the practice, and we would have solved a problem. So moving forwards, once I've got through getting everybody successfully back up and running with their treatment, and I've engaged with the new treatment processes, the next thing I'm going to do is invite the patients in retention back to have a scan, so that in perpetuity, we will be able to manage their retention at times of need and manage it virtually.
And that is a phenomenal advance, not just for dentistry, but lots of other areas as well. And on that, where people start to get things like printers, 3D printers at home, is that going to have a good role to play?
Well, I mean, there are orthodontists that have got 3D printers in their own practices, and they're printing out 3D study models and making retainers on site. Now, what I would have to say, of course, is that the manufacture of a medical device is highly regulated. You know, so to provide a retainer, I would have to be registered with the Medical Devices Agency, you see. So, you know, it would be completely inappropriate for me to make any suggestion that patients would be able to manufacture their own retainers at home. And certainly I don't have the space in my practice, and I don't really particularly want the aggravation of providing it in-house. But you know, sharing images digitally is, you know, my lab technician was used to hopping on a train and coming from Hertfordshire into London, going from practice to practice to practice to pick up impressions and then get back on a train. He's not going to want to do that now. You know, we want to avoid public transport. So fortunately, I had persuaded him to buy a printer and engage with this before COVID. So he's already ahead on the learning curve. And of course, there are people ahead of him as well. You know, I can send my scan to laboratories outside of London quite easily. You know, upload it through a portal. So yeah, it's a very different world.
Sure. And the other thing is, once the braces are off, what do people need to do to maintain that wonderful smile?
Hold that smile, wear your retainers. Yeah, so look, teeth are on the move throughout life. It would be a completely misguided thing to tell people that they can hit a certain age, around the age of 21, and never have to wear their retainers again. You know, in my private practice, I will, wherever possible, give people a fixed retainer which goes behind their teeth, supported by a removable retainer for nighttime wear. That's what ideally I would do.
Well, that's been a fascinating journey. Thank you very much, Claire. Is there anything else to add? I mean, you'll keep us informed of developments in orthodontics, and we looked at in a previous episode that the joy of AI and what that can do. Very interesting to see the use of digital, and as I say, the current circumstances have forced people, if you like, to reassess and maybe actually to look anew at these different areas and the area of technology. But certainly take that first step, get advice. Those are a fantastic initial guide to what is possible.
Yeah. Thank you for your time.
Thank you, Claire. Take care.
Okay, bye-bye.
Bye-bye. So that was Claire Nightingale, Orthodontist of the Year, with a fantastic guide to all things orthodontics from the very beginning, the early stages that you can look at and the different treatments available. If you have any comments, do put them in the section below. If you'd like to write to me at lol, that's LOL, at octopustv.com. But for now, I've been Andrew Eborn. Many thanks again to Claire Nightingale, and I'll see you next time. Bye-bye.